So let's continue our discussion on identifying microbes. As we're trying to identify our microbes, obviously, to get good data at the end, we need to have a good sample going in. Our diagnosis is only as good as the sample that's being collected by the nurse or the medical lab technician or by the doctor. So having the correct technique for collecting, handling, and storing the samples and culturing the samples is of vital importance. It's imperative. Aseptic technique is a given. You've got to practice good aseptic technique. Wash your hands, glove up, sterilize the patient, well, I shouldn't say sterilize, degerminate the patient's skin beforehand. Collecting a sterile sample can be very difficult. So it's easier if you start off with sterile containers to store those samples in. For those of you who are taking micro in a face-to-face setting or have the opportunity to take it in a face-to-face setting, very quickly you'll get to learn about how ubiquitous the pathogens or contaminants are that are floating around in the air and how unbelievably difficult it is to get a truly sterile sample collected. We should be careful when we're collecting our samples so that we can only get samples that have the microbes present from the patient that we're shooting for. So we should only sample the infected site. If you're interested about testing a patient to see whether or not they have a urinary tract infection, generally speaking, drawing blood or getting a sputum sample wouldn't be the best way to go about it. If you're collecting a sputum sample, though, while we're on the topic of sputum samples, we should make sure that we should collect saliva or sputum that has not been contaminated with saliva. Recall, sputum is the mucousy stuff at the back of the throat that's being coughed up from deeper down in the throat. Saliva is present in the mouth. Will have a different microbial profile than the mucus or the sputum from the back of the laryngopharynx area. If we collect a throat or nasopharyngeal sample, when swabbing the patient, we should only swab the back of the throat. We shouldn't swab the sides of the cheeks. We shouldn't rub their tongue, underneath their tongue. Make sure you're only touching the structure that you're trying to collect the sample from. Now, obviously, collecting a sputum sample or a throat swab or nasopharyngeal sample that is devoid of saliva is unrealistic. There's always going to be some contamination. Welcome to the real world. But we should try to minimize that contamination. Occasionally what we can do is intentionally collect saliva and compare that saliva to the sample that we were trying to collect, so the actual sputum sample that we were trying to collect, so we can say, okay, this is what the saliva looks like. So now that I know what the saliva looks like, I can compensate for the contamination of the saliva in my sputum sample. When collecting a urine sample from a patient, you typically want to get a clean catch of the urine sample. Those clean catches are tough to do. Usually, it's easier if the patient has a catheter or some kind of a bladder to collect the urine in. That makes it much easier to get a nice sterile sample, or uncontaminated sample, I should say. The clean catch method, generally speaking, involves watching the outside of the external urethra or urethral opening. This is generally speaking going to be a little bit easier on the patients that have the phallic organ or the male anatomy. And then you let them start to urinate. And that initial rush of urine coming out of the urethra is going to void any potential bacteria that may have been working their way into the urinary tract from the outside. And then partway through the process of urinating, you want to take that collection cup and shove it under the stream of urine to get a midstream catch. So you need to have some good timing and some good hand-eye coordination for this. Any contaminating microbes that are present in the clean catch method can be differentiated from other pathogens. Our dirty catch method is going to be those first several milliliters of liquid that come out of the urethra. So you can have 2 cups present. You can have the patient pee in 1 cup right away at the beginning, fill it up, and then quickly hand them another cup to fill up. The first cup would be the dirty catch. The second cup would be the clean catch. If we look at the urethra, it has lots of mucus lining it, and that mucus can change the profile of the urine. Particularly, this clean catch method becomes much more important when we're trying to collect a urinary sample from a female patient who does not have a catheter. Female patients, of course, have labia minora, labia majora. They have lots of mucus glands in their vulva, and all of that extra secretions and all of those extra yeast cells and bacteria that are present in the vulva cause the sample to become very easily contaminated, making the clean catch that much more important. If we're trying to collect a skin sample from a patient, generally speaking, we're going to swab or scrape away several layers of the skin with a scalpel. And then afterwards, we'll be able to collect our sample. If we're collecting from a wound, we want to cleanse that wound prior to swabbing it for the cultures to avoid collecting any of the normal microbiota that may have been migrating into the wound from around the surrounding skin. To collect a sterile sample from the skin, to collect samples that are from the body that are normally supposed to be sterile samples, such as the cerebral spinal fluid or the blood, we are going to need to use a sterile needle to collect the sample. And we also are going to have to use a very special kind of sterile needle. We want to use a sterile needle that has the hole on the side. We don't want to use a traditional hypodermic needle that is going to have the hole right at the tip. Having that hole at the side helps to minimize the amount of debris that gets pushed up into the sample when we puncture the patient with the needle. We also need to work through antisepsis. Recall, antisepsis is what we do to living flesh. Now, if the patient wasn't alive, we could throw them in an autoclave, we could use incineration, we could use more aggressive techniques to fully sterilize the site. But because we don't want to kill the patient, we'll use some less aggressive techniques, like rubbing with alcohol and rubbing with iodine. And that's called antisepsis. Sometimes you can also collect specimens from the eye, the ear canal, or the nasal cavity, or diseased tissue that's been removed via surgery, and then send those to the lab for analysis. So we've talked about how to collect. Proper collection is very important. We also need to focus on transport and storage as well. Those are also essential. Part of good transport and storage is labeling your specimen. Labeling, and so that you can correctly know what you are working with, is so important. And this is one of those soft skills that most employers at the advisory council meetings that I go to say they cannot be emphasized enough. They want patients, or they want employees, they want nurses, they want medical lab technicians. They want healthcare providers that know how to clearly label their specimens that have been collected so that other people know what to work with. Thankfully, everything is getting computerized now with barcodes and scanners, making that much easier. So if we want to collect samples from a patient, there are multiple ways to do it. We can use a clean catch or a cath for a urine sample. We can use a needle for blood. We can use spit cups, sputum cups, or swabs for the upper respiratory tract. We can use a hypodermic needle for a cerebral spinal fluid collection. We can do a fecal collection in a small capsule. Vaginal swabs are possible. We can use a scalpel to slice some skin off. Or we can rub a Q-tip on the skin, do a skin swab. These are all methods that we have for collecting samples. It should be noted, though, that after we swab a patient with a Q-tip, we need to have a sterile transport mechanism. So that swab is going to start out sterile, and then we're going to take the swab and put it into some growth medium that is also sterile as well. When we look at the patient, the goal always is going to be to figure out what's wrong with them and how can we make them better. So as we look at the patient, we need to go through some analysis. We need to figure out what's wrong with them. What kind of infections do they have? Now, you as a healthcare provider and a primary care provider are going to be looking at them and going, oh my gosh, they obviously have a temperature, or they have some weird colors to their skin, or this slightly gloopy gloppy stuff is coming out of their wound. So you can look at the patient and take some notes and say, okay, here's what I see with my naked eye. Here's some of the gross anatomy or gross features, and those could be very useful. Obviously, we're going to need to collect the specimen and send it for analysis. Direct testing methods are going to be either microscopic, immunogenic, or genotypic or genetic. Sometimes this is also going to involve the cultivation and isolation of the samples. This can take up to a couple days, and it's typically going to be used in situations where we aren't 100% sure about the initial diagnosis based on the symptoms that are being presented, and we need to wait a little bit longer to get a confirmation. Many times a presumptive diagnosis is going to be made. So there's going to be some initial data collected, and based on that initial data, there's going to be an assumed diagnosis made, and that assumed diagnosis is going to be used to start treatment, and then after treatment is started, the isolation and the incubation and identification can be finished to confirm whether or not the correct course of treatment has been taken. Oftentimes, when these results are collected from a patient, these results are going to need to be entered. They need to be documented appropriately. Now, almost nobody uses paper anymore, but occasionally, you'll still see the paper forms. The ability to collect this data, look at it, and communicate it effectively, regardless if it's digital or on paper, analog, is super important. Here's a classic example of a micro sample or a medical lab tech report. So we can identify where the sample came from on the patient. We can identify what was the result of the gram stain, what was the visible result of the wet mount of the culture, what was the appearance of the blood, the appearance of the stool, and we could also say what was the sensitivity to a battery of chemicals or antibiotics. And then based on the cultures, we could say what the presumptive result is for the microorganism. Sometimes we can diagnose a disease quickly without actually analyzing the microbes themselves. We can look at serological tests. These are typically going to be a form of the immunogenic method. So we're going to use antibodies to quickly analyze the patient sample to determine whether or not the disease is present. We also have skin testing techniques. These skin testing techniques are helpful for individuals who've had previous exposure to rubella or tuberculosis. Almost everybody now requires the TB test before you start to work in healthcare. And that's typically just a quick skin test that errs on the side of being safe. It gives false positives, but almost never gives false negatives. Sometimes if we look at our pathogens, we can identify them purely based on the patient signs and symptoms. Sometimes the combination of headache, malaise, pain in the lower right quadrant of the abdomen is so unique or so precise, we can say, okay, based on those specific symptoms, I can say with certainty, this is what your disease is. Unfortunately, that's the exception. So, class, concept check. Care should be taken to avoid contamination with blankety blank when taking samples from a patient. So, to find the answer, please rewind the video, or you can flip back in your PowerPoint slides, or check your textbook. Pause it and get me an answer. 1, 2, 3, 4, 5. Well, this is one of those this is one of those irritating questions. There's a lot of right answers, but there's a best answer. The best answer is normal microbiota. We absolutely do not want to cross-contaminate our sample or contaminate our sample with a resident normal microbiota that are present in the patient. However, other potential sources of contamination could include the air, water, or droplet nuclei, but those are not the big concern. The big concern is contamination with D, normal microbiota. If you have any questions about this material, please feel free to shoot me an email or post them to the discussion boards. Happy studies!